Good afternoon, everyone. Dear friends, my name is Dr. Michelle Albert. I am the president of the Association of Black Cardiologists. And on behalf of the ABC, I welcome you to this very exciting program, which is part of our Table Talk series put on by the ABC CVD, ABC Cardiovascular Women and Children's Committee, as well as our Community Programs Committee, entitled Labor of Love, Barbershop Talk about Fatherhood, Men's Heart, and Mind Health. This is truly an amazing program because for the first time in ABC's history, there is a program that will focus on how Black men can support women through pregnancy, as well as interdigitate the hope of better understanding and addressing disparities, cardiovascular disparities in the health of Black men. I want to thank Drs. Rachel Bond and Dr. Annette Ansong from the ABC Cardiovascular Women and Children's Committee, who have been leading this tremendous Table Talk series. And of course, also want to thank Dr. Paul Underwood and Dr. Daphne Ferdinand, who also co-chair our Community Programs Committee. And I want to welcome and thank all of our guests, participants for this program here today. This program will focus on how Black men can become or increase their advocacy for their mates during pregnancy. And some commentary in this regard. While the support is critical for all women, we know that Black women oftentimes find themselves with unique vulnerability through not only their increased maternal and cardiovascular disease risks that often intersect with each other, but also they're also the harshest recipients of bias across the spectrum globally. Black women also often find themselves alone from personal social perspectives. So it is really exciting to see such a program as the one that you're going to hear today that will focus on how Black men can support Black women. And I, want to close out my opening remarks and get the program started, because I know you're all here to listen to the program, by reciting a section of Maya Angelou's Phenomenal Woman. Pretty woman, wonder where my secret lies. I'm not cute or built to suit a fashion model size. But when I start to tell them, they think I'm telling lies. I say, it's in the reach of my arms, the span of my hips, the stride of my step, the stride of the curl of my lips. I am a woman, phenomenal woman. That's me. And so as ABC embarks on this barbershop talk about fatherhood, men's heart, and mind health, as it interdigitates with support for women, especially Black women, I hope that you remember these sage words from the poem from Maya Angelou. Welcome everyone, and thank you for joining us for this program.
Thank you very much. I am Paul Underwood, and thank you, Dr. Albert, for starting this incredibly engaging program off. I am the co-chair of the Community Programs Committee, and it's really a pleasure that I have to introduce the committee to you and give you an overview of some of the activities that have taken place that have brought us to where we are today. The Association of Black Cardiologists was founded in 1974. And in 1978, we received our first grant from the National Heart, Lung, and Blood Institute to provide community interventions. And we used churches as community wellness centers. Through this, we started using barbershops, beauty shops, and of course, churches as ways of educating and promoting health practices, cardiovascular health practices, to improve the health of our community. Since that time, we've expanded on these efforts. So in the 80s, we started using health screening events, so larger scale events that you may have been, like health fairs, that you may have participated in. In the 90s, we started focusing on generations and longitudinal health. So looking at families and what we can do to make sure that families are healthy from both the childhood and certainly women and men as they age and go through life's phases with respect to cardiovascular health. In the 2000s, we tried to intertwine these aspects of community health screening and education, using some community leadership and getting community leaders involved and making legislative actions, as well as getting spiritual leadership further behind our drive to improve the cardiovascular health of our communities. And in the 2020s, what we've done is just to extend those efforts into long-standing sustainable programs within different cities, such as our Community Health Advocates Training, which is a 12-module section that we use to train the trainer to provide resources, education, as well as engaging community members in protecting their health. And what we found is that through this process, we have developed these different tactics, such as our barbershop programs. We've developed apps that people have used, particularly with barbershop programs or for hypertension management. And we've also participated in research to help people understand how to best intervene on African Americans and to make sure that we all stay healthy. This session tonight is very important because it provides a link that hasn't been there before in terms of having men be assistive in the health of their families. Typically, we think of the woman as being the one that's in charge of the family's health, but men certainly play a component in this as well. And as you're well aware, African American men have flown under the radar for a long, long time. And as a result, we have been suffering from the burden of unhealth, and a lot of that falls in cardiovascular disease. So the Association of Black Cardiologists works collaboratively. So we work very well with other committees, such as our Women and Children's Committee with Dr. Bond and Dr. Ansong. We also work with our Research Committee, our Advocacy Committee, and our Continuing Medical Education and Membership Committee. We're also very anxious to work with other organizations, societies, foundations, agencies that have an interest in promoting the health in the Black community. And it is certainly a pleasure that I have to be a part of this event tonight. I want to thank you for your attention. And I also would like to certainly thank Drs. Albert, Dr. Bond, and Dr. Ansong for their leadership in producing this wonderful program. And remember that a healthy queen is needed for a strong kingdom. So it's up to us to make sure that our families are healthy, and we have to do our part as African American men as well. Thank you.
Thank you, Dr. Underwood. Welcome, everyone. I'm Annette Ansong, one of the co-chairs of the Women and Children Committee of the Association of Black Cardiologists. And we established the Table Talk series in an effort to highlight the spectrum of cardiovascular disease, starting from childhood to women in their reproductive years to the older adult woman. Labor of Love, Part 2, seeks to highlight those issues that affect our Black men, such as cardiac, such as mental, and such as social issues that they're often faced with. It is our hope that you'll find today's event educational and empowering. Without further ado, I'd like to introduce you to my co-chair, Dr. Rachel Bond, who serves as the Systems Director at Dignity Health in Arizona. Rachel, over to you.
Thank you so much, Dr. Ansong. And I have the absolute pleasure of introducing our wonderful panelists as well as moderators, just so we can get started. So to begin, Dr. Branch, Dr. Jason Branch, he has more than 16 years of experience in the mental health and counseling profession. Dr. Branch has worked in community agency and mental health centers, city government, as well as substance abuse treatment facilities. Dr. Branch has maintained a clinical private practice, and since 2010, he's been able to do that focuses on not just adults, but also adolescents, couples, and families. Dr. Branch currently engages in professional and scholarly work focused on African-American male experiences, mentoring multicultural issues, and increasing the practice of self-care for helping professionals. So we're really looking forward to hearing from Dr. Branch, our licensed professional counselor. Next on our panel is Dr. Sei Balaranduro. He is an interventional cardiologist with expertise in cardiovascular disease, clinical research, and global health. He is, as I mentioned, an interventional cardiologist at Inova Fairfax Hospital in the Washington, D.C. area. He graduated as class valedictorian from medical school at the University of Ilorin in Nigeria and was awarded a full tuition scholarship for his master's degree in public health at the Johns Hopkins Bloomberg School of Public Health. He completed his internal medicine residency at the Maimonides Medical Center in New York, as well as his cardiology fellowship at the University of Tennessee Health Science Center, as well as his interventional cardiology fellowship at Columbia University Medical Center, New York Presbyterian Hospital. He is board certified in general cardiology, interventional cardiology, internal medicine, echo, and nuclear cardiology, and has authored over 40 published manuscripts in several distinguished peer-reviewed journals, winning multiple research awards in the process. He pursued a career in interventional cardiology as it allowed him to combine both direct one-on-one patient care with global health in a field that is the leading cause of mortality in the world. His goal is to help patients achieve optimal outcomes through state-of-the-art, minimally invasive cardiac procedures and translate these outcomes globally through health system strengthening and capacity development. Next on our panel is Dr. Keith Ferdinand. Dr. Ferdinand received his medical degree from the Howard University College of Medicine in Washington, D.C. He is board certified in internal medicine, cardiovascular disease, the subspecialty of nuclear cardiology, as well as a clinical hypertension specialist. Dr. Ferdinand is a member of the Association of University Cardiologists, the past chair of the National Forum for Heart Disease and Stroke Prevention, and the prior chief scientific officer and chair of the Association of Black Cardiologists, and presently sits on the board of the American Society of Preventive Cardiologists. He has conducted numerous trials in hypertension, lipids, cardiometabolic risk, as well as cardiovascular disease, especially in racial and ethnic minorities, with over 200 peer-reviewed publications and lectures nationally, as well as internationally. He most recently, in 2019, received the American Heart Association James B. Herrick Award for Outstanding Achievement in Clinical Cardiology. Dr. Mamas is joining us all the way from the United Kingdom. He is a professor trained in medicine at the University of Oxford, completing his clinical training in 2011. He is a professor of cardiology at Keele University and is a practicing interventional cardiologist. Professor Mamas is an associate editor of Circulation Cardiovascular Interventions and a board member of the European Association of Percutaneous Cardiovascular Interventions, the European Society of Cardiology. He is the clinical director of the Center for Prognosis Research at Keele University and leads a group of clinicians, data scientists, and statisticians whose research interests focus around the use of routinely collected electronic healthcare data to inform the diagnosis, treatment, and clinical outcomes of real-world patients with cardiovascular disease. He as well is published in over 500 peer-reviewed manuscripts using big data in populations with cardiovascular disease. We're also very encouraged that we have Dr. Camille Pierre, who also happened to be born and raised in South Florida. He is currently a fellow, cardiovascular disease fellow, and he is a product of two immigrant parents from the beautiful island of Haiti. He excelled in his academics and graduated within the top 3% of his high school. He attended Florida State University on an academic and community service scholarship and has held numerous leadership positions within the student government as well as other registered student organizations while he was enrolled there. He graduated from FSU honors program in 3 years with a bachelor's in chemical science and was accepted into FSU's College of Medicine. While at the college, he served as vice president of the Student National Medical Association and ultimately decided to pursue a career in internal medicine. He matched at the University of South Alabama, where he successfully completed his residency and was appointed chief medical resident and the vice chair of the House Staff Council. He's currently a cardiology fellow at Mayo Clinic in Florida and plans to complete further subspecialty training at Brown University in interventional and structural cardiology. He is married to the love of his life, the former Daphne Cherisol, and they have two beautiful children, Cadence as well as Christian Pierre. Moving forward, we have Mr. Andrew Suggs. He is the CEO of LiveChair Health. Andrew Suggs founded LiveChair, a barbershop reservation app that pivoted into healthcare after his father's health began to decline a year and a half into the venture, eventually leading to an early death at the age of 56 in 2020. Mr. Suggs is a Claflin University graduate and former Claflin collegiate basketball player. He's had a successful career in sales and business development for a major sports franchise and a Fortune 100 company. He received his MBA in 2017, shortly after launching LiveChair. If we could move the slides forward to our wonderful moderators, who I'm going to be handing this over to get started. We have Dr. Columbus Batiste, who's a board-certified interventional cardiologist and assistant clinical professor at the University of California School of Medicine. From 2008 to 2020, he served as the chief of cardiology. Over the years, Dr. Batiste has been recognized for his work in the community and abroad by multiple organizations. In 2010, he sought to break the cycle of prescriptions and procedures as the sole management of chronic disease and began promoting a long-term solution for his patients through nutrition, stress reduction, and exercise. As a result, in 2011, Dr. Batiste established the Integrative Cardiovascular Disease Program based at Kaiser Permanente. Dr. Batiste's mission is to share information so that each one can teach one about the benefits of plant-based nutrition, daily exercise, and stress reduction, and therefore provide everyone with the opportunity to take control of their health. And lastly, we have Dr. Rimsky Denis. Rimsky Denis is an interventional cardiology fellow at the Johns Hopkins Hospital with future plans of completing structural cardiology training. Prior to beginning his cardiovascular disease fellowship, he completed his internal medicine residency at Brown University in Rhode Island and his medical school training at the University of Miami Miller School of Medicine. Rimsky holds a master's degree in public health with a concentration in disease prevention, as well as a master's degree in business administration with a focus on healthcare policy. His research interests pertain to the assessment of health inequities within structural heart disease, as well as interventional cardiology. He is a native of Florida and currently resides in Baltimore, Maryland. And with that, Dr. Batiste, I hand it over to you to start our discussions.
It's a pleasure to be here. And this is an important month. This is an important conversation, so to speak, a barbershop conversation. So it's a pleasure to be here. We know that we're in the midst of an ongoing battle since the early 1900s in the Spanish flu and cardiovascular disease. We know that cardiovascular disease has really disparaged our communities, and it's the number one killer for men. We know that it accounts for 1 in 4 deaths every single year, and the number one cause of death in men. What we know is that specifically as we look at the plight of African-American men, that Black men, unfortunately, have an overwhelming burden of disease that they experience. And so what we know is that Black men have a substantial amount of cardiovascular disease, with nearly 2 out of every 3 Black men have heart disease over the age of 20. So that means that nearly 60% of men, 58% of women have some form of heart disease. And as a Black man, there's an even higher risk or chance of dying, especially at a younger age. What that means in sum is that Black men are living sicker and dying sooner than others as a result of cardiovascular disease. We turn our attention to Darrow, and many of us may be able to resonate with this sort of story of Darrow. You know, I certainly do, growing up in the inner city of South Central Los Angeles. Darrow is an overweight, he's an African-American male, teen, 17 years of age. He's a bit overweight. He smokes menthol cigarettes. He's dealing with the recent loss of his best friend, who died as a result of gun violence. He lives in a densely populated neighborhood with poor air quality, where, you know, it's really difficult to buy affordable or good quality fresh food. He's frequently stopped by the police. His father works two jobs just to support the 3 children, his siblings, as a single parent. Since Darrow's mother died at childbirth, Darrow hasn't seen his pediatrician in a few years. This story really resonates with many people who I knew growing up inside this community. I want to stop and pause for a second as we listen and reflect on Darrow's story. I want those who are listening right now, tell me, what do you think is his greatest contributor to his heart disease? Would you say that it's his smoking? Is it his increase in weight? Is it the lack of medical follow-up? Is it racism, police profiling? Is it the pollution? Is it the zip code, or is it all of the above? Pause for a moment and give me your thoughts. All right, as we look at this poll and this question, wonderful. We're seeing here that the majority of people are saying all of the above. Some have said that it's the weight, and I would agree with all the above. What we know in general is we know that zip code oftentimes predicts a person's mortality, right? It's what we call a combination of social determinants of health that we'll speak to, but it's all of these have been shown distinctly in medical literature to have an association with increased disease burden that's preventable. When we look, there are traditional risk factors. So when someone comes to my clinic, there are things that we cannot change at all. Our age is going to be what it is. Our gender is going to be what it is. Our family, we can't change our great grandparents at all. And those are what we call non-modifiable risk factors. And then we have those modifiable risk factors that are classically taught. We speak of high blood pressure. We speak about high cholesterol. We speak about diabetes and smoking, excess alcohol, obesity, and also sitting, right? Lack of activity, physical inactivity. But there are also a degree of non-traditional risk factors which have increasingly come to attention to the public at large. They've been inside of the realm of science for a while. We look at inflammation and autoimmune conditions. We look at lack of sleep. How many of us suffer with the lack of sleep? We look at racism and its toll in our body in producing these effects. We look at chronic stress, anxiety, and depression, the role of mental health, and we look at something called social determinants of health. Now, what exactly are social determinants of health? In some, it's where we're born, where we live, where we work, and where we play, where we die. These are the areas: our education, our access and quality to education, our healthcare access, the quality of our healthcare, the neighborhood, the pollution, the environment, the access to food, the walkways and parks. We look at the social and community context as well. Those things are the components, and we look at the economic stability is what we look at when we're speaking about this role of this. So I want to turn our attention to a question or two. And first, I'd like to direct this question to Dr. Ansong. And so if we look back ideally, Dr. Ansong, at Daryl's story, and if he were seeing a pediatrician, what recommendations would they give Daryl to decrease the chances of developing heart disease in the future?
Thank you for the question, Dr. Batiste. So Daryl has a number of risk factors, but the one that stands out to me, because I see it so commonly in my pediatric practice, is obesity, where 1 in 5 children is overweight or obese. And of course, it affects our Black and brown children the most. So as a pediatrician, I think what we need to do and be more aggressive about is identifying those children who are overweight and obese and targeting our efforts towards mitigating those risk factors. I see obesity almost as a gateway disease, because more than likely, if a child is obese, they also have one other cardiovascular risk factor, such as high blood pressure, such as high cholesterol, such as diabetes. So we need to encourage and educate our parents and our kids on exercising. Children should engage in at least 1 hour of exercise every day, good heart healthy eating habits, increasing the amount of fruits and vegetables in their diet, drinking water, because water is not only good for hydration, but it also gives us that feeling of fullness, so we're less likely to eat those unhealthy foods. So those would be some of my recommendations to Daryl's parents and pediatricians.
Love those, love those, love those. Those are some sage words of advice, not only to our kids, but to our adults. And, when we look in general as a whole, one of the things that we find is that Daryl also had a plethora of other issues that were going on with him in terms of his use of smoking. And I'd like to turn this question over directed to Dr. Ferdinand. And so, Dr. Ferdinand, what is the significance really of menthol cigarettes versus non-flavored cigarettes? That was something that was an agent of choice for Daryl.
It sounds strange that you're going to pick out a type or class of cigarettes for a group of people, but it's no accident. Menthol cigarettes are flavored with a peppermint-like taste and they're so you can look cool and feel cool when you smoke. And I'm using that word cautiously because they were aggressively targeted specifically at Black youth. Many of you may be a little young, but at one time there were even jazz festivals and pop festivals with the cigarette company sponsoring Black images, playing jazz and playing music, and suggesting that if you wanted to have that type of lifestyle, you would smoke their cigarettes. There's going to be some action coming up, and we can talk about that. But historically, 85% of Black smokers use these menthol cigarettes. And again, that's no accident. It's because of marketing targeted directly at Black consumers.
And that role, speaking a bit more as it relates to that, and that's troubling as we look and reflect on this historical implementation of attacking certain communities. But have there been any recent legal legislative initiatives to really combat this?
Sure, there have been campaigns for smoke-free children, and the FDA has just released a suggestion that they're going to ban these menthol cigarettes. Flavored cigarettes no longer are available. You can't get an orange flavored cigarette or a fruit flavored cigarette, but you can get a menthol cigarette. And the FDA in its preliminary action has suggested, because of this history of targeting especially Black and minority communities with menthol cigarettes, and also you see it the same with those communities where you have sexual gender diversity. These things are purposeful. It sounds odd. You really wouldn't think that a big Fortune 500 company is going to pick out one segment of the population and say, this is the segment I want to target, but it's real. And it's real related to menthol cigarettes. Later, we can talk about diet, fast foods, fried foods. These things that you see and hear and are in print are not by accident.
Yeah, and it appears as if it's targeting our youth as well, given the flavored aspect of things as well.
That is correct.
All right. I think that brings us to a poll question. And so for those of you out there listening, I want you to think about this for a moment. Why can smoking lead to heart disease? Why can smoking lead to heart disease? Is it because it causes the arteries to harden and to thicken? Is it because it reduces the good cholesterol, your happy cholesterol, HDL? Is it because it raises the blood pressure, or is it a little bit of everything? All right. The answers are in. All right, and the vast majority looks good. They are correct. I would agree. Would you agree, Dr. Ferdinand?
Yeah, they got it right. Smoking is one of the worst things you can do. There's nothing good about smoking. It inflames the vessels. So the vessels themselves have plaque inside of them. And persons who smoke, there's more of a likelihood that plaque will rupture, like a blood clot or an infected knee when you skin your knee playing ball. That's inside the blood vessel. That plaque, when it ruptures, can occlude the vessel. If that blocked vessel is in the heart, that's a heart attack. If the blocked vessel is in the leg, that's peripheral arterial disease and can make you lose your toes with gangrene. If that blocked vessel is in the neck, it can lead to a stroke. One of the good things, though, is that if a person stops smoking, their risk of having a heart attack is cut in half in about a year. So it's not something that you have to live with. You can stop. And if you do stop, it decreases your risk of having a heart attack.
That's incredible. That's incredible. It speaks to the power of the body to heal itself. But, as we look at this a little bit further, and thank you so much, Dr. Ferdinand, for your expertise, I want to shift the conversation to some of the things that we learned about Daryl's story, and that may resonate with many of those tuning in right now, is that, we know that over-policing happens far too many times in community of color, right? And it really traumatizes individuals at that point who suffer with that. And they're associated with it, and it usually gets swept under the rug. And so I want to turn this question to Dr. Branch, and how can psychologists collaborate with other physicians to really address these traumas, these tragedies, almost creating this PTSD like syndrome impacting Black teens such as the biological effects of over-policing and gun violence. I recognize this in my own son, who's 14, and his fear over things that transpire. So if you can shed light on that, that would be great.
Absolutely. An excellent question. Thanks for having me here. So one of the biggest things is the transition between helping professionals like psychologists into physicians. More than likely, Black teenagers will see a physician before they see a psychologist. So the physical health is what we address usually because we can see it, we can feel it. The mental health, we don't talk about as much. So typically those collaborations come from within, as in a physician may refer to a psychologist or psychiatrist more than a psychiatrist or psychologist to a physician. So the first thing is that connection. Let's have a conversation. Let's talk about it. Let me refer you to somebody. I deal with physical health. Let me send you to someone who deals with mental health. Also, for us as Black male helping professionals, rather in the mental health profession or physical health profession, we ourselves, how can I support a young Black man to go to therapy if I've never experienced therapy myself? So for us, we need to experience some things ourselves as far as therapy to encourage other people to go, especially Black men. So as a Black man, as a mental health professional, I share with my clients, I go to therapy. Absolutely, because it changes the stigma and beliefs about therapy. So for me, it's having a conversation. How can I have a conversation about something I haven't experienced myself?
Wow, that's deep. I love that. I love that. We need to experience that ourselves before we can sell it to our patients. That's powerful. That's powerful.
Absolutely.
All right. Appreciate you. Appreciate you. You know, we're talking and we're focusing really here in the United States, but we have to wonder, is the same experience of people of African descent the same across the world globally? And so I want to turn to you, Dr. Mamas, as we look at really the role inside the UK. Are we seeing many of the same things? We saw a mirror-like reflection of the disparities with COVID, but are we seeing the same things with risk factors in the UK? The disparity, what disparities are you seeing there?
So thank you for inviting me to contribute. This is such an important meeting. So as way of context, in the United Kingdom, we have a universal healthcare system. That means everyone gets free healthcare access. So with that sort of system in place, you would think that, we don't have these disparities, but that's very wrong. So first and foremost, deprivation. We know that deprivation is probably one of the strongest risk factors for cardiovascular disease. About half of all premature deaths relate to socioeconomic disparities. We know that an average of 6 years of life is lost in patients that lived in the most deprived areas. And who lives in these areas? Well, 60% of Black patients live in the most deprived areas, even though they are a minority of the population, whereas only 20% of whites live there. To give you some more statistics in the UK that will really shock you, and remember, this is a universal healthcare system. On average, Black men get cardiovascular disease 6 years younger than white men. For women, this data is even more shocking. On average, a Black woman will be diagnosed with cardiovascular disease, wait for it, 14 years younger than a white woman. Mm-hmm. Unbelievable. And the risk factors are very similar. I mean, smoking, high blood pressure, obesity, diabetes, very similar in the UK, even though we have a universal healthcare system.
Wow. 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 That's powerful. That's powerful. Living sick or dying sooner. We're going to continue this conversation really of Daryl, and I'm going to turn it over to my co-host and Dr. Denis.
Thank you, Dr. Batiste. Right. So in continuation with Daryl's story, we see that Daryl is now 24 years old, and he's a graduate of an HBCU. We also see that he's a member of a Black fraternity and also plays basketball occasionally. He visits his local barbershop once every few weeks and occasionally attends church on Sundays. He works as a teacher in an underrepresented neighborhood. As many who attended college or undergrad, he has gained the freshman 15 and is currently suffering from insomnia. He continues to be stopped by police on a weekly basis, unfortunately. In addition to that, Daryl still smokes methanol cigarettes, which he uses as a way to deal with the microaggressions that he deals with at work. He has yet to establish care, unfortunately, on a regular basis with a clinician as part of routine care. With regard to the multitude of things that are affecting Daryl in his life, we see that there are segments of Daryl's community there are segments of his community that create opportunities for decreasing his cardiovascular disease risk. We see that his barbershop community is one of the major, opportunities whereby his risk can be decreased. In addition to that, his faith-based community, where he attends church on a regular basis, can also, assist in decreasing his risk. Him being able to exercise and give back to his community can also help with stress with regard to decreasing his risk. As it pertains to cardiovascular risk, I wanted to relay this question to Dr. Ferdinand. And I wanted to ask Dr. Ferdinand specifically if you could share ABC's 7 steps to heart health and also the American Heart Association's Life Simple 7. If you could discuss these in further detail, and also talk a little bit more about which you think best summarizes the opportunities to address the risk factors that are specific to Daryl's story.
Sure. So when you look across the landscape in the United States, and you look at various risk factors. A risk factor is the chance that something bad is going to happen. For instance, if you're on a highway, you're driving at the speed limit, a young man may come by in a motorcycle doing 100 miles an hour, and they'll go so fast that they lay out on the bike, no helmet, no jacket, nothing. Very risky behavior. So the American Heart Association looked at a series of risk factors, things that if you didn't do, would increase your chances of having a heart attack and stroke. And they called it the simple 7s. I'll go around the dial. Let's start at 1 o'clock, diet. And you see the picture of the fresh fruits and vegetables. There's some fish there, which is a lean source of protein. Then there's body weight. We've already spoken about that. And we've heard from the pediatrician, the cardiologist, that it starts early in childhood. Exercise. Now, exercise is a kind of a misnomer. It really doesn't have to mean going to the gym. It just means having physical activity. And it not only can be going to the gym, it could be walking, bicycling, using light weights at home, dancing, gardening, and even housekeeping. Who wants to clean their house? But that is a form of activity. Avoiding vices, and I think we've already talked about smoking and the targeting of the Black community, especially with menthol cigarettes. The FDA is going to probably bring that to a halt. Blood pressure, we're going to talk about that in a little bit. That is a powerful risk. Then we look at cholesterol, and we've talked about that. That actually is linked to the diet, as is diabetes. The next slide shows the 7 steps to healthy heart from the Association of Black Cardiologists. And Dr. Denis, it's kind of funny. We developed the 7 steps before American Heart Association's Simple 7s. So this has been around. B. Wang Kong was CEO of the ABC many years ago, at least 2 decades ago, and looked at some things that we could all do in our community to live longer and healthier lives. And along with some of those same risk factors that I just described, we also built in a certain degree of spirituality. Now, we're not saying that you should go to church A or synagogue B or to mosque C, but having that sense of community and belonging is one of the best things you can do to increase your health. And by increasing your health, we had another saying that we developed 2 decades ago: children should know their grandparents, meaning that we wanted to see Black men and women who were dying earlier in life live long enough to see the fruits of their grandchildren.
Thank you so much for that response, Dr. Ferdinand. As it pertains to the different segments in Daryl's life, we see that he actually attends or goes to a barbershop, as many African-American men do, on a regular basis. It was mentioned earlier that there was an organization called Life Chairs. I wanted to address this question actually to Mr. Suggs. I wanted to see, Mr. Suggs, if you could elaborate on what exactly is Life Chair and how does Life Chair specifically work to decrease cardiovascular risk factors?
Hey, so this is Andrew Suggs, co-founder and CEO of Live Chair Health. So Live Chair Health, we build networks of clinical and non-clinical resources like barbershops, hair salons, and churches to address minority health disparities. by accessing, engaging, and influencing hard-to-reach populations, African Americans specifically, to take a wide variety of coordinated health-oriented actions. And so what we do is we train barbers on being essentially health coaches and advocates. We set up a kiosk in the shops that allows each client to complete a health risk assessment. And then from that health risk assessment, our technology creates a health journey for each client. So that first starts by ensuring that each client has health insurance, because if you don't have health insurance, it's very hard to access healthcare. Once you have health insurance, we connect those clients with the primary care provider. And once we connect their client with the primary care provider, they get a report card basically of where their health stands. And we help them manage that chronic disease. So whether it be hypertension, diabetes, other cardiovascular diseases, we give them the resources through our partnerships and through our technology. And then for taking those coordinated actions and improving their health, we reward them with discounted or even free haircuts based on tiers that are hit. So what are we doing specifically to address cardiovascular disease? Hypertension screening. So we have a focus on hypertension screenings with our staff members being trained on how to take blood pressure readings, because one, it's a non-invasive screening. Within 45 or 60 seconds, you'll get a reading, and it really allows us to communicate to a client basically like almost like a check engine that, hey, something is going on here and you need to do something about it if you want to be here and to live longer and healthier. So that's what we're doing specifically. So I'll pause there.
Sounds like you guys are doing phenomenal work, Mr. Suggs. Just to delve into your organization a little bit further and go into the history, can you give us a better understanding as to what the impetus was with regard to launching this? What was the specific reasons as to why you all felt this organization needed to exist?
Yes, great question. So we began the business as a scheduling and payment processing app for minority hair professionals. So that's how we were in barbershops and hair salons in the first place back in 2017. And as our business was growing across 27 states, we had thousands of clients using the booking app. My dad's health was declining, and curiosity led my co-founders and I to do research on health disparities, and not having that formal background in healthcare, either through academic training or clinical training. I was really startled by the huge chasm between ethnic minorities, African-American men, and in particular in the general population. So in 2019, we wanted to do something about it. So we participated in the American Heart Association Empowered to Serve Business Accelerator, where I met Dr. Ferdinand mentioned Dr. Kong. Met Dr. Kong. He is actually one of our advisors, our clinical advisors in our model. And shortly after that 2019 Business Accelerator, my father's health declined to the terminus point, and he's no longer with us. So he passed away from congestive heart failure at the age of 56. So the impetus for me to pivot the business away from business management software into healthcare is because of my father. And I firmly believe, had Live Chair Health been here, 15, 20 years ago, that he would still be here, because 4 days before he passed, we all can guess where he was. He was at his barbershop. So it's an access point. And I know that just as a point in terms of the evolution, because we have B. Wayne Kong on our team, barbershop and hair salon initiatives aren't a new thing. They date back to when B. Wayne Kong and Dr. Elijah Saunders launched the first one over 40 years ago. And so what we're trying to do differently from a Live Chair Health perspective is create a sustainable model, which is why we are for profit, so that the engagement and the data that we collect and utilize, we're able to create that sustainable business model. So
thank you so much for that response, Mr. Suggs. We know that these issues are not isolated to the United States. We know that these issues are global, which leads me to Dr. Mamas. I wanted to have you touch a little bit on what specifically is going on or being done in the United Kingdom with regard to reducing these poor outcomes that have been heavily discussed throughout the course of today's presentation. Is there anything that's being done to target socioeconomic issues, or are there any government initiatives specifically addressing these issues in the United Kingdom?
So generally in the UK, as I mentioned, we have a universal healthcare system. And as part of that, at the age of 40, everyone is invited to see their primary care physician for a full cardiovascular risk assessment, including blood pressure monitoring. The problem is that these programs generally don't resonate with our minority patients. And so we really have to find more innovative ways of capturing patients and assessing them in their communities. And again, in the UK, we have very similar systems. For example, outreach services to measure blood pressure in barbershops, in bus depots. So there's been some great programs in some of the areas in London where there's large Black populations. But we have other programs as well. So for example, the My Action program, which is a program which involves a nurse, it involves a dietitian, and it also involves a physical therapist. And these three individuals go to community centres and engage with local communities. And they've been shown to be efficacious, reducing weight of patients, reducing smoking, and improving blood pressure control. The big problem, though, is funding these initiatives. And I think, you know, in times of economic problems, these initiatives are often the first to go. And I think, you know, it's a great shame. And I think, you know, these are things that we need to invest in heavily. If we don't reach our communities, then we're going to have these disparities in health that we're seeing.
Certainly, Dr. Mamas. You know, one thing I also wanted to highlight was some of the work that's currently being done, you know, by the ABC Community Programs Group with regard to the barbershop initiatives that have taken place in Baltimore and also most recently in the Delta in Mississippi and also in Jackson, Mississippi. Not too long ago, we were able to work with the Department of Health in Mississippi with regard to training roughly 50 barbers on how to adequately measure blood pressure. In addition to that, we also educated them on a host of different issues ranging from diabetes, hyperlipidemia, and also other risk factors pertaining to cardiovascular disease. It was a well attended initiative. It was also well received by the different individuals who were able to take part in that session. And from my understanding, they have since been able to disseminate that information to a multitude of individuals in their communities. The goal is to ultimately plug these individuals who are determined to have high or elevated blood pressure in with a community health worker who will then lead that individual to be screened or be seen rather by a physician or a healthcare worker in their community. To date, the organization down in Mississippi has been doing this for roughly 8 years, and it's our goal to partner with them in addition to other organizations throughout the nation. So this is just one of the low-hanging fruit that we see that we can take advantage of, particularly as it pertains to Daryl's story, which is not uncommon to most African-American men here in the United States. Moving forward, we see that Daryl is now 27 years old. We see that Daryl is engaged, and he has added some exercise to get in shape for his upcoming wedding. He misses his doctor's appointments regularly that are scheduled by his fiance, and he seems to never reschedule them, unfortunately. But while at the barbershop, there's a health fair and his blood pressure is checked. He is told that his blood pressure is mildly elevated, and it is recommended that he see his doctor or a doctor, because again, he doesn't have much access to a physician. However, Daryl he says that he feels fine, and he says that he doesn't have a primary care doctor, so he doesn't make much effort to follow up on those recommendations, unfortunately. Research has shown time and time again that men are generally less likely than women to seek out healthcare in the United States. And in the United States, men on average die almost 5 years earlier than women. This is an unfortunate statistic, and we believe that is likely linked to the fact that men do not access the healthcare services, in similar fashion as their women counterparts. In addition to that, we also see that mortality rates for the leading cause of death, such as heart disease, cancer, and stroke, are unfortunately higher in men when compared to their women counterparts, particularly those before menopause. With that being said, there's also a significant amount of mistrust within the Black community for healthcare in general, or the healthcare institution in and of itself. There's a significant degree of iatrophobia that exists amongst Black men and Black women. This question I wanted to direct it to Dr. JB. As an African-American man, Dr. Branch, as an African-American man living in America, and as a medical professional, who handles issues centered on mistrust of the system. This question is directed to you. Why do you believe men, in particular, Black men, tend to be less likely to seek healthcare services? Is it simply an XY issue, or is there something else, that contributes to why they seek healthcare on lower rates?
Absolutely. There's several reasons. There's not just one. Some of the main reasons that come up is mistrust. I don't trust people that don't look like me. And within the profession, as far as medical profession, there's not a lot of Black doctors, Black male doctors specifically. So therefore, I don't trust them. So I'm not going to see them. Also, for us as men, we're not taught how to take care of ourselves when it comes to our physical health. If my dad doesn't go to the doctor and never goes, I'm not going to go. In addition, the cost. I may not have insurance. I may not have access. I may not know. And it's scary. It's uncomfortable. I don't have people talking about it. So there's several barriers that prevent Black men from going, and mistrust. And with this particular person, Daryl, he went to HBCU. He's in a Black fraternity. He wants to see a Black doctor, and he may be limited with that. And therefore, there's another barrier there. I don't trust them. I trust somebody that looks like me, and therefore I'm not going to go.
It's very insightful. Thank you so much for that. But as it pertains to some of the things that can be done with regard to patients, this question I'll actually address it to Dr. Bolarunduro. Dr. B, what do you do specifically to address these issues in your patient population?
Yeah, so, there's a major questions that we have, and was pointed out multiple times, there are issues of trust. You have a patient come in, comes in, we sit down, we talk. And then I try to first of all, they're surprised to see someone that looks like them. And then we talk and we engage, and then we just go down to the fundamental thing. We don't have the physician relationship where the physician is high up, he tells you what to do when you can't speak. So that camaraderie. So for me, the way I approach it is this. I say, look, I'm like a coach. We're just like you got your goals. You want to have your fitness goals. You want to be this. You want to have your physical goals and your health goals. You want to live long. You want to see your grandkids. You want to do all these things. And then together we just come up with a plan. So the way I approach it is this. I'm not a physician telling you have to do this and point out medications. I'm just telling you this is where you are. Where do you want to be? And then together we say this is where you want to be. So between now and my next appointment in 6 months, what are you going to change? How are you going to change it? What goals do you have? And together we go through the same things on those 7 steps. The smoking. Okay, how much do you smoke right now? Are you going to quit by then? Do you want to drop it to half? And then together we come up with a plan. I think that's one of the major things that is lacking. The fact that people don't see somebody who looks like them, who connects with them, who understands where they're coming from. So I think that's where we as physicians, we as Black physicians need to, make sure that we are partners with this, and then together we work towards getting to that goal.
Thank you so much for that response, Dr. B. As it pertains to medical adherence, Dr. Ferdinand, could you discuss a little bit more about medical adherence and how you also discuss those issues with regard to your patient population? And could you also touch a little bit on the patient-provider relationship and how important that is, particularly amongst individuals of color?
Well, I think it was well articulated that the doctor-patient relationship, the provider-patient relationship, is one of the most sacred human interactions that we have. It's up there with priest-parishioner. People tell you their inner secrets. They believe in you. So if we're going to try to have patients take their medications, control their blood pressure, change their diet, stop smoking, that relationship is key. First, you have to sit down, eye level, literacy appropriate. Big words. What does that mean? Talk to people's language. Don't tell a person, we think you have adenocarcinoma of the lung. I saw a patient last week who had that in his chart. When I told him he had lung cancer, he was floored. And I tried to figure out what could have happened. And I think some doctor mumbled to him after bronchoscopy, you have adenocarcinoma, and the guy didn't know what the heck he said. Use the appropriate language. Feel the person's pain, the empathy. And then educate the patient about what happens if you don't control your blood pressure or you don't take your medication. The direct relationship between elevated blood pressure starts at about 120/80, And every 5 millimeters of mercury, you go 125, 130, 140, 145. The higher it goes, the increase is the risk of a heart attack, stroke, heart failure, peripheral arterial disease, and chronic kidney disease and end-stage renal disease. So I think it's a combination, Dr. Denis, of being with the patient in their life journey, educating the patient, and empowering the patient. We're talking here about men, but it also goes for women, empowering the patient to be a partner in his or her care.
Definitely.
Now, there's certain tools, if you're talking specifically about blood pressure in this case, for instance, there are text tools where a person can measure the blood pressure at home with a validated blood pressure cuff, and then by Bluetooth, the measurement will come back to us. There are different companies. There's one out of Canada called Sphygmo. Our chair, Dr. Elizabeth O'Feely, has developed one. And these tools allow patients, even in the home setting, to communicate electronically with their doctor.
So Dr. Ferdinand, you touched on some remote patient monitoring or remote healthcare monitoring. Could you elaborate a little bit more on some of the apps that may be in existence with regard to encouraging compliance and encouraging healthcare visits?
Yeah, now during the pandemic, I actually stopped going to the clinic for a while, not only because the patients were afraid to go, but I didn't want to get COVID myself.
I see.
And I started to do a lot of telehealth using valid blood pressure tools. There are even electronic scales that can Bluetooth back to the office. You're able to communicate with patients similar to how I'm talking to you now over the internet. I still believe the human touch is important, and I'm very pleased that I'm back in the clinic and able to sit down and touch patients and listen to their lungs, check their pedal pulses, that's the pulse in the foot, check their calf muscles to see if they have a blood clot. So that's really important. And I'm not downplaying that at all. I think that's one of the best parts of being a doctor is touching patients.
Definitely.
But we now have tools, apps, where the patient can measure his or her blood pressure. It goes into the cloud. I can see it on my smartphone. And then when it's time for their visit, whether it be in person or by telehealth, we can actually discuss what their blood pressure is doing. As I mentioned, Dr. O'Feely has been a pioneer in that field. And there are other apps that other people can use. I think it's one of the best developments perhaps that came out of the pandemic. Not much good has come out of this terrible scourge, but the ability now to recognize how we can communicate with our patients electronically has been probably one of the few benefits as it relates to healthcare.
Certainly in this digitized environment, that's a tremendous help with regard to, increasing compliance with regard to our patients. As it pertains to the clinician, it's important that we all remain mindful of certain health disparities in efforts, to take care of our patients as a whole. This question is directed towards Dr. Mamas. How is medical education being tweaked today to incorporate social determinants of health, implicit bias, and also structural racism?
So I think in the United Kingdom, we are increasingly recognizing the problem of structural racism and implicit bias. And many medical schools, including my own, the University of Oxford, encourages or actually forces all students to undertake implicit bias assessments. And I think this is really important. We have to recognize our own implicit biases. All of us have them, and being able to identify what they are is important. I think second of all, and importantly, it's very important to highlight disparities amongst different populations that we serve. And that's very much part of our medical education, understanding social determinants of health and understanding how certain communities have worse outcomes than others. And finally, it's around mentorship. So for example, in my research group, I'm the minority. I'm the only white individual in my research group. All the physicians that work with me are physicians of colour. And it goes back to one of the very important points that one of the other panelists said, that actually communities are much more likely to engage with physicians that look like them. And that's important, that we have to promote physicians and increase the number of Black and Asian physicians in our workforce. We don't do that, and I make a particularly special effort to try to do that, because I think that will serve our communities the best.
Thank you so much for that response, Dr. Mamas. in continuation with Daryl's story, I'm going to transfer it over to my colleague, Dr. Batiste, to continue with what's going on with Daryl.
All right, thank you. So one of the things that we see with Daryl is that Daryl now is 32. He's entering this phase of life now, and he's expecting a second child. You know, their first pregnancy was uneventful. His wife, Amira, currently is at 38 weeks gestation and is reporting dizziness, headaches, and not relieved by medications and stomach ache, right? Her blood pressure is 135/85. She has been evaluated by her OB, who reassures her, the patient, that, but does not order any tests or any other studies, despite the concerns that are there. Her symptoms remain ongoing, so Daryl insists that he attends the next meeting, right? And that's always extremely powerful to have family members there. And at the next appointment, Daryl supports Amira's concerns. By now, her blood pressure is 145/90, and he insists on a workup. The doctor complies. She is diagnosed with preeclampsia. She is admitted to the hospital for observation and management. Eventually, she undergoes induction of labor and has a healthy baby girl, Mia. You know, I want to turn our attention right now to one of the things that we see prevalent inside of the United States is the U.S. is the only industrialized country with the worst rates of death during pregnancy and the postpartum period. These rates affect Black women, who are 3 to 4 times more likely to die during pregnancy and the postpartum period compared to their white counterparts. The leading cause of this death is heart disease. And the common reason for this is because Black women's voice are not heard. This impacts Black women and infants across socioeconomic and education. And what that means is that irrespective of education and status, we're still seeing this. And so I'd like to kind of turn our attention over, and I'd like to loop in Dr. Pierre. And, you know, as a Black man whose wife was recently went through childbirth, can you emphasize or relate to Daryl's experience at all?
Absolutely. Thank you for your question, Dr. Batiste. To visualize your wife's suffering and then to have her concerns dismissed is absolutely heart-wrenching. My wife presented to the hospital about a week after her delivery with right upper quadrant pain, shoulder pain, and was crying. My wife doesn't cry pretty much for anything. And my daughter, who was sitting next to her, started crying as well because she'd never seen her mother in so much pain. And so we present to the emergency department. She's found to have a couple of leukocytes in her urine, and the PA says, "Oh, you have a UTI. This is clearly what it is. We'll send you home. Don't worry about it." And I said, "There's no way." My wife has had urinary tract infections before in the past. She's never cried. There has to be something else. You know, I requested a CT scan and they scoffed and they said, "No way, but you know what? Just to calm your fears, we'll do an ultrasound." After they did the ultrasound, they found all this fluid within her abdomen concerning for blood. They ultimately performed the CT scan. And unfortunately, my wife was diagnosed with a large adenoma inside the liver, which is a benign mass that bled profusely. She lost about 2 pints of blood during the hospitalization. I mean, thank God I didn't lose her. And so if I didn't say anything or we didn't complain or ask for further issues, I may not have my wife right now.
Wow. And that seems like that's an important aspect to this conversation, is really as it relates to the role that the partner can play really in accentuating the concerns of the person who is the patient. Would you agree with that?
Absolutely. You have to insist, you have to demand, you have to make your concerns known to the physician or the nurse. The healthcare facility will respond when a patient or family member is not happy with the care that they're receiving, or they're concerned about the care that their family member isn't receiving. So if somebody's ignoring you, you go to somebody else. And if a hospital ignores you, go to another hospital, go to an ED. But don't return home if you're concerned that your spouse or your child or your mother is suffering from an issue. That can save a life if you stay persistent.
Wow. Thank you, Dr. Pierre, for sharing that personal story like that. When we look at race, ethnicity, and social determinants of health, and we know that this indeed can actually increase these conditions. We know gestational diabetes, peripartum cardiomyopathy, and what that means is the heart actually becomes weak from the stressors of pregnancy and so forth during that period of time. We know that increase the risk for cesarean sections. We know that increase the risk of early births, preterm deliveries, and low birth weight children, and independently increasing the rate of future cardiovascular disease. We know too as well that the contributors to this, structural racism, has a significant impact on this. And we know too as well this cumulative biological stress, it's identified as enhancing African Americans, women's susceptibility to these health problems. And I'd like to turn to Dr. Bond and really speak a little bit more to these, and what are the tools that Black families can use to advocate for their birthing partners?
Yeah, thank you, Dr. Batiste. That's a wonderful question. And I think you highlighted so nicely that what's at the core of the disparities that we're seeing, again, all centered around these social determinants with structural racism at the very top of that. The fact of the matter is that Black women are dying, as you very nicely pointed out, 3 to 4 times the rate of their white female counterparts. And what we as a society can do, there's a multitude of things. Factors such as bringing the partner to the visit is one key thing. I think it's exceptional that Daryl, as well as Dr. Pierre, was an advocate for their partner, because it really led to better outcomes. And that, of course, is not in line with what we're seeing nationally. But what other tools can we kind of give our partners, or the partners of these females, is to make sure that they understand the signs and symptoms to look out for. The fact is that heart disease is the leading cause of death, as well as morbidity, meaning poor complications during pregnancy. But it's important to emphasize that could be up to 1 year after they deliver the baby as well. So looking for classic signs such as headaches that may not be going away with the use of Tylenol or other medications, shortness of breath that's out of the ordinary, swelling in the legs that's also not being relieved by raising your legs or just not going away. In addition, any pain or pressure in your chest that also seems to be not going away. More notably, we talked a lot about blood pressure, specifically for Amira's case. Her blood pressure was slowly creeping upwards, and that could definitely be a red flag that there may be the possibility of preeclampsia pending, which is again on a spectrum when it comes to blood pressure. But I can't emphasize enough, as this slide very nicely highlights, that the first step is to acknowledge the Black mother's concerns. As women, we know our body better than anyone else. When pregnancy hits, it is a stress test. And if something doesn't feel right, we need to be vocal about it. And as a partner in that care, you need to make sure that your partner's voice is listened to and heard. Steps that have been extremely helpful, if you move to the next slide, have included the use of doulas and midwives. We also know that the nurses also have a tendency to be strong advocates for that patient, at least in the hospital setting. But I can't emphasize enough making sure that the men, as well as partners of these women, have all the tools in place to understand what those risks are and make sure that at the end of the day, these voices are being listened to and not silenced.
Love it. Love it. That's great. That's phenomenal. When we look at this, I want to kind of turn additionally here, Dr. Pierre, can you address what toll it really takes on your own health? I mean, as you watched your wife and the struggles there, what toll it took on your health?
It was difficult. I mean, not only physically does it take a toll, because now you're basically the only person there to kind of help take care of your brand newborn at night, and so you have to feed him every 1 or 2 hours with formula. But also physically, I mean, thinking, is your wife going to come back home? Are you going to get a phone call that she's not doing too well, she has to be transferred to the ICU? So, I mean, and she was at the hospital for 4 days. So constantly thinking about that, constantly being fatigued, just having to take care of your newborn, as well as my other daughter. Thank God my in-laws came into town, but the stress is real. It's nothing that I've ever encountered before. And so these self-care tips are ones that I would definitely recommend to anybody who has to go through this, scheduling some me time, reading books, discussing the pressure to protect, and give yourself some permission to cry, give yourself your permission to feel that things just aren't going well, that you're just kind of waiting for something good to happen. And discuss the pressure to provide with somebody. And at the end of the day, if it's okay to seek professional help. This really comes at you really quick and really hard, and somebody may not know, a lot of family members may not know how to deal with this. So find somebody who can kind of walk you through professionally how to deal with this mental anguish is something that I'd highly recommend.
Love it. Love it. Dr. Branch, I want you to chime in real briefly and tell us about men. This idea of self-care has been promoted for women an awful lot, but give us some additional ideas for men with self-care.
Absolutely. I like to keep it simple. ESPM. We got to work on our emotional, spiritual, physical, mental, is making investments every day, not waiting for the weekend, not waiting for vacation. What brings joy to my heart? That's my emotional. What brings joy to my spirit? What uplifts my spirits? Physical. What do I do to enhance my body? And then mental. just like was mentioned, professional help, going to therapy, saying no, setting some healthy boundaries. It's amazing that a lot of us as Black men, we think we're Superman, but the reality is Superman can't save the world. He saves who he can. But how can I save the world if I'm not willing to save myself first?
Love it. Love it. That's one of the key things too, as well, that we have to recognize. We have to know really our numbers. We have to treat our bodies like a business. And so do you know your numbers? Do you know what your blood pressure numbers are? Do you know what your bank account numbers are? You probably do. Do you know what your partner's blood pressure numbers are? Let's put the poll question up there and see how many of us know our blood pressure. And the corollary to that is, do you know what is good in terms of your numbers versus not? All right, but go ahead and respond to that. Wonderful. So we're seeing roughly around 25 to 30% actually don't know what their numbers are, but wonderfully 74% do know what their numbers are. So I want to encourage those who don't know what your numbers are, don't pause. You don't have to own a machine. Just go to your local grocery store or pharmacy. You can have your blood pressure checked easy in your own time, but it's important for us to do that. This phase I'm going, and then the second part of the question is, do you know what your partner's numbers are? Right? Do you know what your partner's numbers are? All right. Yep. Interesting. So roughly 55% know their partner's numbers, and 45%, roughly 44% do not know. And so it's important as a team that we rely upon each other. I'm going to turn back over to Dr. Denis to continue on with Daryl's story.
Thank you so much, Dr. Batiste. In continuation with Daryl's story, we see that he's now 37 years old. And while playing basketball, he experienced some left arm weakness. He tries to shake it off, as many of us guys do, but it is clear to his frat brothers that something wrong is going on. Daryl is reluctant to call 911, but he goes to the hospital anyway, right? He's given a test and he's diagnosed with hypertensive emergency with a blood pressure of systolic 180 over a diastolic of 100 millimeters mercury. Daryl, unfortunately, or fortunately in this case, is admitted for observation. He is initiated on blood pressure medications and he is subsequently discharged home. He makes lifestyle changes. We see that Daryl unfortunately went down a path that led him to unfortunate outcomes, although he had many opportunities for prevention. One of the opportunities was getting counseled or getting assistance at his local barbershop, in addition to his church and other, community agencies that were afforded to Daryl at that time. It should also be noted that Daryl had several risk factors, including weight, high blood pressure, methanol, and social determinant of health issues, in addition to significant stressors in his life. Dr. Pierre, could you elaborate on what is hypertensive emergency, given that Daryl was found to have that when he presented to the hospital? What exactly is hypertensive emergency?
Thank you for that question, Dr. Denis. So hypertensive emergency is an acute rapid rise in blood pressure that leads to damage in a target organ. That organ can be the brain, the heart, the kidneys, or the eyes. In Daryl's case, whenever you have that acute rise in blood pressure, you can get swelling within the brain. And depending on where that swelling is, you can have dysfunction or weakness in a particular portion of your body. In Daryl's case, that was his left arm weakness.
So we see that Daryl, like you said, did have left arm weakness, and it's oftentimes associated with a stroke. Could you please describe the different symptoms with regard to the management between a stroke versus something else that may be benign?
Phenomenal question, Dr. Denis. So a stroke is when a vessel within the brain either bursts and causes blood to enter the brain, or there's a clot that blocks that vessel. This will lead to decreased blood flow to a portion of the brain, and that portion of the brain will die. Typically on imaging on a CT scan or MRI, a doctor can see the blood within the brain or a clot within the brain. Now, the treatment for these two are vastly different. With hypertensive emergency, you simply rapidly bring the blood pressure down, particularly within the first 2 hours. When it comes to a stroke, things are more complicated. If there's a blood clot, the physician may recommend some blood thinners to thin out that blood. If the blood clot is in a particular favorable area, that physician may then do a minimally invasive procedure to see if they can extract that clot and have resumed blood flow to the brain. If there is bleeding within the brain, however, surgery may be required.
Thank you so much for that distinction, Dr. Pierre. And this question I'll direct it to Dr. Bolo Rundo. Left arm weakness or numbness oftentimes is associated with a heart attack as well, although it is usually associated with chest pain. Heart attacks are typically associated with chest pain. How would Daryl's diagnosis and treatment be different if he were having a myocardial infarction, Dr. B, or a heart attack?
So Daryl, like we pointed out, had gone through a lot of risk factors, and all those risk factors lead to, end organ damage. So the brain, the heart, the kidneys, like was pointed out. So now he could have easily, the same way he had the hypertensive emergency and had the complication neurologically, he could have had a similar thing going with his heart. With a high blood pressure, he could have had what we call a non-STEMI. He could have had, a dissection. He could have had a myocardial infarction. And so most of them, like we pointed out, are associated with left-sided chest pain. Some of them will have, pain and numbness on the arms. Sometimes they might have a numbness. They might have a feeling like, oh, I just feel like my arm is vague. I feel like I just couldn't do something. There was just something there. Daryl is a regular patient I see. I see patients who happen to look like me and are a certain age group, younger than me, coming in and then they're having a heart attack. And so, it's important to point out that, even though you feel like you're less than 40 years old, and oh yeah, you're too young to have a heart attack, it could happen because all these risk factors have been coming with him from childhood. And yes, he's young and everything, but it's important to make sure to know that. So the treatment would be, if it was a heart attack, we will be looking trying to decide if it's a STEMI or a non-STEMI, which means is the artery 100% closed, or is it, partially closed? If it's, it's 100% closed, we go quickly through the radial artery or through the artery in the groin. We go take a look at the arteries, and then we put a wire through it, put a balloon, and put a stent in, which is what we do quite regularly. Even if it's not 100% blocked, if it actually has caused a heart attack, we'll be doing the same thing. For some people, it's a warning, and then it means you just need to bring down the blood pressure, just like he had in the hypertensive emergency situation.
Thank you so much, Dr. B, for that distinction. And also thank you again, Dr. Pierre, for those distinctions as well. We see that the underlying factor with regard to the stroke and the potential heart attack was control or lack thereof with regard to Daryl's blood pressure. Dr. Ferdinand, could you elaborate a little bit more as to why blood pressure is deemed the silent killer? And also, what are some of the things that we can do or some of the tools that we can implement to maintain a control or have a control of adequate blood pressure?
Well, we used to call it the silent killer because early on when the blood pressure is elevated, you feel pretty good. But I think all of you have now described that especially once it becomes very high and damages the organ, we call it target organ damage, whether it be the brain, the heart, or the kidneys, it's no longer silent. One of the best things you can do is, first of all, get your blood pressure checked, have it evaluated. We've talked a lot about not only checking the blood pressure in the so-called doctor's office, but checking it at home, checking it in the barbershop, the beauty shop, at church, and other venues. Low sodium diet, having a lot of salt increases blood pressure. Too much alcohol, psychosocial stress, weight gain, and a lack of physical activity, all of these add to elevated blood pressure.
Thank you, Dr. Ferdinand. In essence, there are a multitude of things that can be done in efforts to maintain proper blood pressure control. In continuation with Daryl's story, we see that Daryl is now 47 years old. He quit smoking after his hypertensive crisis episode. We see that he's now taking all of his medications as prescribed. He's working out regularly. He's eating healthy foods, and he sees his doctor on a regular basis. But unfortunately, Daryl continues to experience the life stressors, and he is now a father of a 17-year-old son and a 15-year-old daughter here in the United States of America. Now he wants to pass down better health advice or better health habits to his son and his daughter. Again, we think that we strongly believe that not smoking or abstinence with regard to smoking is one of the best things that Daryl can encourage his son and his daughter not to do. In addition to that, he can encourage them to do some of the things that he's now doing right now, right? Eating a healthy diet, a healthy balanced diet, exercising regularly, right? And doing certain things to mitigate certain stressors that one can experience in their life. moving forward, or I like to direct our attention to this poll question here. As it pertains to poor mental health, right? We know that it increases long-lasting chronic physical conditions, right? Which one of these conditions do you all believe is impacted the most, right? Would it be heart disease? Do you guys believe it's stroke? Do you guys believe that it's cancer? Or would you say that it's all of the above? Give you guys a second to respond there. I'll go ahead and respond myself. And as stated in some of the previous slides, the answer is, as you all, 90%, 91% of you all indicated, it's all of the above, all the above. Moving forward to the next section, I'm going to pass it off to my co-moderator and colleague, Dr. Batiste, to continue with Daryl's story.
Wonderful. Thank you. Thank you. All right. One of the things we know, we've been talking about mental health and its effects on the body as a whole, but what about the mind in totality? We know that suicide, it's become the second leading cause of death for Blacks or African Americans ages 15 to 24. This wasn't always the case. We were not leaders as it relates to suicide. Black children are more likely to die by suicide than their white peers. One study found that between 1991 and 2017, suicide attempts by high schoolers decreased for whites, Latinos, and Asians, but the number went up significantly for Blacks by 73%. It's troubling. It's troubling for the parents out there. It's troubling for us as a society. And so I want to turn briefly to some of our panelists. Dr. Branch, if I can loop you into this, discuss the stigma really still that exists with Black men and our sense of manning up around mental health and not wanting to embrace it. And I think the real question is, what can we do to destigmatize it? And you touched on this a bit earlier, but if you can re-highlight that.
Absolutely. To me, the first process of desensitizing is we have to be willing to become comfortable being uncomfortable. What that means is having courageous conversations, talking about therapy. A lot of us within the Black community, it's Jesus or bust. It's not Jesus and therapy. And the reality is you can do both. So it's having those conversations, it's educating ourselves about it. It's being able to talk to our friends, our family about it, and even experience. So try therapy. If you've never tried it before, step outside your comfort zone and just try something new and different. That stigma is there and it will continue to be there until we start having courageous conversations.
Yeah. And just to follow up on that briefly, what are some resources for those who may be a little apprehensive? And, are there resources available for the Black men in need of mental health support?
Absolutely. The first one that steps out to me the first is Black Men Heal. Therapy for Black men, psychologytoday.com. And I'll put this in the chat box too, so you'll have access. But there's a lot of resources out there, but those resources doesn't mean anything if I don't know about them. So it's our job to find out. We have Google, we have so many resources to connect to find what's out there, but we're not willing to do it. We research what we know. And I challenge all of you, Black men who haven't experienced it, try therapy, reach out and connect with someone. Get the information for yourself, not from what you hear from other people.
Wow, appreciate that. We're going to pivot slightly, but along the same lines of Daryl kind of addressing his mental health for the purpose of his family and his own longevity. Dr. Ansong, tell us really, how can his new healthy habits in general that were spoken about previously have an impact on his children?
Thank you for the question, Dr. Batiste. So this is why Black fathers matter. The healthy habits that Daryl displays could literally save the lives of his children, because they see firsthand and up close what healthy living is all about. And children are like sponges. They see what their parents are doing and they're going to want to emulate that. And he's showing that he's not only just talking the talk, but he's walking the walk. So the healthy, positive actions that Daryl is displaying could have a huge impact on his children.
Oh, I love it. That's profound. It's just on an epigenetic level. Not only is he able to transform his own DNA, but even his kids through emulating that. That's powerful. And so, are there tips for Daryl on encouraging his children to have heart-healthy lifestyle habits that can help prevent them from having the similar outcomes as him? And really, I'm speaking to these teenage years. When there's independence that starts to mount.
Absolutely, which is a challenge, teenage years. But Daryl should keep as he is, which is walking the walk. You can't tell your children to eat fruits and vegetables and you're holding a Big Mac in your hand. So we have to show to our kids what healthy living is all about and involve our children. I think what's very impactful is when families do things together. If there's a child that is identified as obese or having these cardiovascular risk factors, as a family, they should try to make changes, not just the child, eat healthy food together, exercise together, walk outside together, so that everyone's involved and everyone can aim towards healthy living.
It's great advice. It really is great advice. Thank you for that. As we look in general at how to equip yourself, that's one of the things we're looking at. How do you equip yourself for all of the things we're confronting in terms of the health challenges of living, improving, and refining ourselves? And I think the first step, we look at engage, right? We encourage you to discuss race, your feelings, your stress, acknowledge it, say it out loud, your fears, acknowledge the daily impact that this has on your physical and mental health and well-being. I think that this is powerful. I think 2020 taught us this, that we have to be able to look. There's so much swirling around us and our kids. We have to at least acknowledge it. I think the second step is we talk about mastering it, right? Understand your risk. I want you to rely on the trusted healthcare provider, but you need to understand what's around the corner lurking for you. Understand your risk and the 7 steps to prevent and control them. There's power in your hands, and it's been described throughout this entire message here. The last phase is for you to activate. It's not enough for you to engage and master, but you have to activate it. You have to seek out trusted messengers, right? People that believe in you, that resonate with you, to support your mental and physical wellness. And this is one of the powerful tools that we can embrace to achieve the health that we're looking for. I'll move on. I want to make sure that we discuss some of the valid resources. We talk about resources. Where are some of the resources? Because there's so much information out there. It can be a bit overwhelming. Who do I trust? Do I trust Dr. Google? Do I trust this person or that person out there? And so I want you first to acknowledge that there are people out there who have your best interests in heart, like the Association of Black Cardiologists, the American Heart Association, CardioSmart, Million Hearts Initiative, Men's Health Network, the Balm and Gilead, Black Men Run, Black Men Heal, right? Therapy for Black Men, Black Mental Health Alliance, Centers for Disease Control and Prevention, National Health, Heart, Lung, and Blood Institute, and the Office of Minority Health. There are trusted resources. Make sure that you are seeking a reliable source as you're seeking out information to impact the health of yourself and your family out there. I want to turn to the next question. Any questions at all? Turn this to question and answer period of time from any of those who are tuning in.
Thank you, Dr. Batiste. There's actually a question I wanted to pose to Dr. Mamas. As someone in the UK who treats patients of color, what advice do you give to other clinicians, Dr. Mamas, on providing culturally competent care?
One of the most important pieces of advice that I also give to my children is that the Lord gave us 2 ears and 1 mouth. And so use them in that ratio. Listen to patients. That's so important. We've heard from many of the panelists here this evening that physicians often don't listen enough. And I think it's really important to listen to what your patient is telling you, understand what your patient is telling you, and try to make changes, not all at once. If you go to a physician and you say, well, you need to lose weight, you need to stop smoking, you need to do this, you need to do that, patients are going to think, well, what the heck? Better take it a step at a time. And the final thing, and this is probably the most important thing, I always ask them about their loved ones. Do you know what their blood pressure is? Do you know what their number is? If you don't, please tell them to go to their primary care provider, the general practitioner, and get them checked out. It may be the most important thing that you do today.
Thank you, Dr. Mamas. And speaking on advocacy, Dr. Pond, could you speak on the role of doulas as advocates for pregnant women?
Absolutely. I know that was a really important question that was raised earlier. So the way doulas are, they are part of the healthcare team. However, they're not healthcare professionals. They have the opportunity to be there through every stage of that maternal continuum. Again, starting even as early on as preconception. And that's really where I would encourage you to start talking to the doula so you can work with them on perhaps even painting what your delivery plan would look like. They also will be there for you during the delivery. So they're basically your eyes as well as your ears in the event that there are any issues that may arise. They obviously have experience and a lot of exposure. And we know that data has shown that women of color, specifically Black women, benefit immensely from having a doula part of that care team. They can help support your partner, they can help support your family. So we at the Association of Black Cardiologists have partnered with many different doula organizations to really try to uplift their presence as well as their voice in terms of dealing with the disparities that we're seeing in women of color, specifically Black women, when it comes to the maternal health crisis.
Thank you so much, Dr. Bond. Question from our audience. So we spoke a bit on the role of barbershops and churches in screening for cardiovascular risk factors. One of our audience members wants to know, what if there are folks in the community that can't access those points due to poverty and ultimately end up dying? This is to all our panelists. What are the means in which they can be screened? For anyone?
Well, Dr. Ferdinand, it's often very difficult for people who don't have any form of insurance to get care. In fact, if you look at poor blood pressure control, incidence of chronic kidney disease, heart failure, heart attack, strokes, the highest group of people who don't have insurance. One of the things that I would suggest that they would do is to seek what's called a federally qualified health center. These are centers where persons who don't have any insurance can get heavily discounted care, and they're usually found in most places in the neighborhood. Also, we talked about the barbershops, the beauty shops. That's not going to be present in all neighborhoods, but we still have church programs. And if there's a church that's within walking distance or a short bus ride, they often will have health ministries that have free health care. Well, it's not care, we'll say diagnostic screening to see if you have high blood pressure, diabetes, cholesterol. But I think to get care, which is an ongoing thing versus screening is just checking, federally qualified health centers, they call them community health centers. They're located in most neighborhoods.
Thank you, Dr. Ferdinand. My next question is for Dr. Branch. Within your own practice and among other colleagues, what are you seeing in regards to how the mental health of Black men has been impacted by the COVID-19 pandemic?
Yeah, with COVID, there's a lot of disparities that happen with Black men. Number one of the biggest is job loss. So losing their job, losing family members, losing relationships, and just not having access to being able to get out of the house and do different things. So a lot of it has increased some depression, some anxiety, some stress, you name it. It's a lot of different things that's happening, specifically to Black men because of the coronavirus.
Thank you. And this last question is going to be for all our panelist members. What are some action plans to mitigate these disparities in care?
Well, I'll go first. As a society, I was very heartened to hear that the United Kingdom has universal healthcare, meaning everybody can get to see a physician and they're screening at 40 years for heart disease and stroke. In the United States, we don't have that. I think we all should be activists to have our so-called leaders, political leaders, do the right thing and make sure that we have universal health care.
Thank you so much, Dr. Ferdinand. Dr. Bond, I'm now going to turn it over to you for closing remarks.
Thank you so much, Dr. Ansong. So in closing, I think we can all conclude that this was a very fruitful discussion. I hope that you really have learned a lot in terms of the tools that you can do to not only advocate for yourself, but also your partner. And that was really the premise of this and why we as the co-chairs of the Women and Children Committee wanted to partner with the Communities Committee to really get this messaging out there. We are so fortunate to have the support of all of our wonderful panelists, as well as our wonderful moderators who did such a phenomenal job to really walk us through Daryl's story. I'd like to talk a little bit about an upcoming event that really is very similar to this event in that it's focusing on men's health, as June is Men's Health Month. It's called Stepping Up for Men's Health, Fit for Life. It's Saturday, June 26th at 1 p.m. Central, and a few of our ABC members will be joining in. It is co-partnered in co-partnership with the Association of Black Cardiologists, particularly the Communities Committee, and we're really looking forward to that event. We also encourage those on the call, if you are not quite yet a member of the Association of Black Cardiologists, to consider membership, as well as possibly even supporting it in other ventures. As you can see, we're doing a lot of work with communities at the core, which is really those grassroots efforts. And we really would appreciate any further support, but also membership. And as Dr. Ferdinand very nicely said, we always look forward to partnership with other societies as well. And lastly, as I said, thank you again for joining in. We really do appreciate it, and we want to stay as close to the time commitment as we had asked, but we did go over a little bit, but I do think, again, it was a fruitful Q&A session. So once again, thank you, and we look forward to you joining us next time. Thank you.